Assessment of suicide risk should never rely on suicidal ideation as the only determinant of risk. There are many factors that inform suicide risk, thus it is vital for mental health clinicians to assess all known risk factors. What are the risk factors for suicide? Henry Ford, the birthplace of zero suicide, divides suicidal risk factors into acute, high, moderate, or low. Of note, there is no category of no risk, as those patients who come to a mental health appointment, by definition, have some level of risk. These risk factors have been derived from patient research as well as studies using artificial intelligence to retrospectively identify risk factors of those who have ended their life by suicide or made a suicide attempt. Importantly, risk factors enable a clinician to choose interventions that modify the risk of suicide. So what are the various levels of risk? Acute risk factors include such symptoms as psychosis with command hallucination, suicidal plan, suicidal intent, hopelessness, or a suicide attempt within the last 30 days. What are high-risk factors? These may include symptoms or facts such as a history of suicide attempt in the last year, severe anhedonia, a response of 2 or 3 on question 9 in the PHQ-9, alcohol abuse or substance abuse within the last month, or global insomnia. What are moderate risk factors? These may include facts such as moderate anxiety or panic, suicidal ideation or response of 1 on the PHQ-9 question 9, a history of suicide attempts more than a year ago, or a family history of suicide. And lastly, what are low risk factors? These include the fact that even when an illness is in remission, such as major depression, bipolar disorder, or psychosis, a patient still retains a risk of suicide. Mental health clinicians often thoroughly assess suicide risk at intake and when the patient complains that they are struggling with suicidal thoughts. It is vital, though, to reassess at every patient encounter because the nature of suicide risk is that it varies over time.
The following is a demonstration of a behavioral health encounter with a patient who has indicated a risk for suicide.
So you told me in the last couple months you've been really struggling with feeling depressed. And with the depression, you've had a couple severe symptoms. It's been hard to sleep. You've been withdrawing from friends. It's been hard for you to go to school. Hard to concentrate on your schoolwork. And that you've had thoughts of even ending your life, which from what you told me is very unusual for you. The second thing you told me about is that even though you were a social drinker before, that lately you've been binge drinking, maybe as much as a pint or even a fifth at one sitting. And that also, you've had some blackouts. It's also made it hard for you to function and go to school. Did I get that right?
Yeah, pretty much.
Okay. So what we're going to talk about is what that means in terms of diagnoses and more importantly, what it means for treatment. Because the good news is that all these things are treatable. So in terms of the depression, you meet criteria for what we call a major depressive disorder. It's the most common kind of depression that affects people. And men are about 1 in 10 risk of developing in their lifetime. And the symptoms that you described, depressed mood, anhedonia, fatigue, insomnia, and thoughts of death are all part and parcel of that. We know that some people, about 50% of them, may have one episode of depression, but many people have recurrent episodes throughout their life, again, very treatable. You've also told me that often you drink and that meets criteria for alcohol use disorder. And commonly when people are feeling depressed, they may drink more in an effort to try to feel better, although you've probably noticed that often it makes you feel worse after the first drink.
Yeah, it does.
So we're going to spend some time talking about treatment, but before we do, I want to talk a little bit about suicide for 2 reasons. One, that you tell me you've struggled with it. 2, you told me that as an adolescent at 12 or 13, you actually took an overdose of medication after the breakup with a girlfriend.
Yeah.
So men are about 4 times more likely than women to end their life by suicide. So we want to talk about suicide and some strategies to help you with that, because it can be very painful.
Yeah. Okay.
So the nature of suicide is that it comes and goes. So what we want to give you as many strategies as we can so that you don't end your life, and that when you feel that way, you have some tools to help yourself feel better. Now, one of the tools we use the most is called a safety plan. It seems very simplistic, but has very good literature and research showing that it can help save lives. So I'm going to give you a copy and then a pen, and we're going to walk through and show you how to do this. So the first step in a safety plan is for you to think, what are the warning signs that tell you that you might start to feel suicidal or even act on that? Step 2 is coming up with what you traditionally, before you got depression, did to feel better. So everybody has tricks to, for lack of a better word, self-soothe. So historically, what have you done to feel better? The third step is really, what are the reasons to live? I mean, I know we may not think about it this way, but everybody has things that they take pride in that give them joy in life. Now, the fourth strategy is, you may be in places at times where you can't do those self-soothing strategies. All of us probably have thoughts, memories that we think about that gives us pleasure, gives us peace. Think of some things that may be self-soothing thoughts or memories. Now, the fifth step is really to list people that you could talk to or contact if all these things don't work. Who could you reach out to that could be supportive and that you could share what you're going through with? Now, the sixth step is really, if all of that fails and you're not getting enough support and you're still plagued by suicidal feelings, the professionals you could call. I know that your therapist referred you, so let's put his name down as a therapist, and then you can put my name down as someone to contact as your psychiatrist. And then the last step that you can see, step 7, is really saying, if all that fails or you can't reach people and those suicidal feelings become intense, then we want you always to go to the nearest emergency room where they can further assess and help you. The other thing that we do when people are struggling with suicidal feelings is we want you to know what emergency services are available. In the United States, there's now a suicide and crisis line called 988, which is free of charge and available to talk to a counselor 24/7. You don't have to be suicidal to call. You can call if you're just having a bad day and you need someone to talk to and no one else is available. I'm also going to give you a list of some resources, books, websites that you can use to learn more about depression and alcohol use, and I'll circle the ones that I think might be the most helpful to you. Okay?
Okay.
And then what we're going to spend the last time talking about is we'll talk more about treatment of depression and alcohol in terms of medications that we could use and in terms of the talking therapy you have with your therapist. Well, we spent some time talking about how you've been feeling and the diagnoses that you're struggling with, major depression and alcohol use disorder. And we spent a lot of time talking about suicide risk, because that's important. It can sneak up on people. People could feel not suicidal one day and be overwhelmed with those thoughts the next. So we spent some time talking about antidepressants that you're going to be on, the referral to AA to help with alcohol and to give you more support, the safety plan, and we'll make copies of that before you leave, and the books and community resources and emergency services that are at your beck and call whenever you need them. What I want to leave you with is a lot of hope. They're very treatable. You also have a lot of very positive protective factors and a lot of things going for you in your life, a lot of things to live for. And that's always important to keep in mind. So we're going to see each other in 2 weeks to follow up. And between now and then, if you have any questions, I want you to call me. The key to the Henry Ford Zero Suicide Guidelines is to identify and modify suicide risk. So what does this mean? It means changing how care is delivered and organized. Suicide risk mandates a psychiatric evaluation, so care must be organized to deliver that type of an appointment. For example, acute risk usually requires a psychiatric admission. High risk requires a psychiatric evaluation, as well as evidence-based psychotherapy in the form of a partial hospitalization program or an intensive outpatient program or individual therapy. All levels of risk require discussing with the patient means reduction, specifically the removal of firearms from the home. It also requires self-management tools. These, by definition, must include a safety plan, but may also include educational resources such as books about depression or websites which can educate the patient about their illness and treatment. Family support and involvement is vital when a patient agrees to such. Educational material for the family so that they can act as allies to the treatment team in recognizing suicide risk are important. Lastly, particularly with the advent of 988, a suicide and crisis line, it allows patients to have 24/7 resources even when their treatment team is unavailable.